We are happy to have you here in the first meeting of the International Network of Cancer Field Surgery in Gynecological Oncology. So today we have you here, Professor Höckel. It's a great pleasure to have you here, and we are really happy to interview you and to ask you some questions, which is quite interesting for us, and we hope that the same question will be interesting for you. So the first question is, dear Professor Höckel, you were born in post-war Germany, a time of immense challenges and rebuilding. Could you share how your early years and education shaped your path into the medicine?
Yeah, I was born in the 1950s into a middle-class family in the Rhine-Main area, and we and many others in our country were fortunate and happy because of the so-called economic miracle. So we had quite good starting conditions, and that meant for me I had a childhood and youth which was quite happy and interesting because so many new things arose around me. I went to school, elementary school, and then to the gymnasium, the higher school, and finally made the last exam before going to university. Well, during that time, I encountered a lot of interesting subjects, and medicine was one of them. Actually, I don't know what made me drawing when I was 10 or 11 years old, a scene from an OR, because I've never been in an OR. Nevertheless, this picture exists from 1960 or so, and it shows a surgical team, a patient, anesthesiologist, everything and everyone in an OR. So obviously at that time I had already some motivation, but there were so many other areas I was interested in. And when I had to select the subject of my studies in the university, I had difficulties. Actually, I did not know what to study because so many things were interesting for me. I was interested in biology, interested in geometry, interested in Latin, and a lot of other subjects. And so how to find the right path, the right subjects to study in the university. Actually, I did a negative selection, what I did not want to study. And finally, there were two areas of interest. One was medicine, indeed, and the other was chemistry. Because I always had the idea of an exact science, but on the other hand, I wanted something to apply. And so because I could not decide between chemistry and medicine, I studied both. And went through all the semesters and examinations, and finally did even make a doctoral thesis in both cases. So of course, during the study of chemistry, I specialized in biochemistry. So I always try to find my way. But this was not a one direction route to my final position and interest, but it was a path of many blind endings. So I went one pass and I found out this is not the right way, a second one, a third one. So finally, I could not really decide between real science and applied science in terms of medicine. I made both. And when I had to decide what profession I should go after being qualified both in chemistry and in medicine, I choose OB/GYN, obstetrics and gynecology. Why? Because I went through the campus of the university hospital and looked at the parking spots. And there was one hospital with the most Porsches. There were 4 Porsches. You know Porsche, the German racing car. So, and I thought this would be the best option for me, because no, that's absolutely not true. You know, it's a joke. I'll tell you, it's a joke. I'm absolutely not interested in cars, and the decision I made was based on the dual pathway, because OB/GYN has endocrinology, and endocrinology is chemistry, and because I still adhered to both, I choose obstetrics and gynecology with the aim to finally to combine these 2 lines of interest. And yeah, that's more or less the way which I went when I was a child, a young boy and a young adult. So many interests finally distilled and condensed to 2 ways which are still active when I started my career as a physicist.
Excellent. So Bruno, next question. Turn on your microphone.
Sorry,
Yeah.
can you hear me?
Yeah.
Yeah.
So, Professor, let's move to question number 2. So the question is, what initially drew you to oncology and surgical anatomy, and how did your early experiences shape your approach to cancer surgery?
Well, that's another long way, because we are now at the beginning of the OB/GYN pathway, and I still had in mind to combine both science and applied medicine. And at that time, I had the opportunity to get a chemical substance called angiotropin, which induced the growth of blood vessels. At that time, it was a very exciting substance, and I wrote Judah Fogman, who was the Pope at that time, and actually he invented the field of angiogenesis and angiogenesis research, and he was he chaired a big laboratory at Harvard University. And I wrote him and I told him, I have a very interesting substance producing blood vessels. If I could come and experiment with this substance in his laboratory. And he agreed. So I went to Boston, Harvard Medical School, and did a lot of experiments with already set up instrumental settings in his laboratory and showed the activeness of this substance to produce new blood vessels. The result were the first papers in highly ranked journals, and still it was separated because doing experiments with cells and substances is still far away from medicine, from applied medicine. So I had the idea to make new blood vessels in surgical situations when they are needed. That is in wound healing, and particularly in compromised wounds. So I made a model of compromised wounds in the ears of rabbits. And I applied this substance, and it shows effect. So wounds which otherwise under normal conditions in artificially set up wounds healed, whereas without this substance they did at least partly fail. So I came closer to both fields by applying the angiogenesis factor to a medical problem, particularly in reconstructive surgery. But after that time at Harvard University, coming back to my old university, where I was trained in obstetrics and gynecology, I realized that it is impossible to continue experimental work in the high standards which I found at Harvard University. So it was another blind ending, if you say so, because it was working quite well in the conditions of fantastic laboratory, which I visited and worked in Harvard Medical School, but at my university in Mainz was impossible to do. Also, I found out that doing really professional experimental science, biological science, demands your full time and your full profession. Like, for example, Judah Forkman, who was a pediatric surgeon before he decided to become interested in angiogenesis and developed being the world leader in this field. So it was another limit and blocked a way for me, which I initially thought it would be possible. However, at that time, I became more and more interested in practical surgery, because obstetrics and gynecology is definitively a surgical discipline, and so the medical road became broader as compared to the scientific road. But still there was my interest in real exact science as well. And I looked for another field where I can combine both interests. And of course, doing gynecology, doing gynecologic surgery made me encounter cancer, gynecologic cancers. So the next pathway I went for some time was tumor oxygenation, because tumor oxygenation depends on vascularization, and tumors are very poorly vascularized, or maybe not poorly, but in a poorly effective way. So the blood is not providing enough oxygen, and tumor tissue has to cope with this situation, and is an important factor for becoming more and more aggressive. Because of the selection of tumor cells within the hypoxic microenvironment. So I measured in cervical cancer tumor oxygen, and again a series of papers came out which were interesting in that way that under certain circumstances the oxygenation status was an indicator of the aggressiveness of this tumor. Though that was a time when, again, I had the two paths, the clinical path and the scientific path, and we are approaching in the timeline to the end of my training as a gynecologist. And in that at that time, still walking the two ways, I at first were introduced into radical surgery, particularly into radical hysterectomy. So we are now at the end of my specialty. Usually that's a time where the trainees get to radical hysterectomy.
So it's quite interesting because angiogenesis is quite often mentioned in your work, in your courses, and it's quite interesting that your career was started with this topic. So the next question is number 3. Before you developed the principle of cancer field surgery, how did you approach the surgical management of gynecological malignancy in your early practice? What limitation or frustration with conventional techniques ultimately inspired you to seek a new paradigm?
Yeah. When I had the opportunity to learn radical hysterectomy, I found out very early that that procedure at that time was a very crude procedure with large clamps and very bloody. And despite of this practice, adjuvant radiation was given. I could not understand why all these therapeutic modalities had to be combined, and still a lot of patients, particularly with advanced disease, relapsed. Young women relapsed. Terrible situations I was facing at that time. Patients with untractable sciatic pain, with elephantiasis of the leg, and I was very disturbed at that time. What I realized again with my second path of exact science is that the anatomy where radical hysterectomy is working in is a black box. That's the subperitoneum, and the subperitoneum is divided into spaces and ligaments artificially by the preparation of the surgeon. And I noticed that there was many differences in spaces and in ligaments, which are not real structures, but which are artifacts of the surgeon. And I thought this could not be an optimal procedure because it is so variable, it is so crude, and the effect at that time is really, really poor. And fortunately, at that time, a new technology in diagnostics arose, and this was MRI, magnetic resonance imaging. And magnetic resonance imaging, for the first time, gave us, and me included, a real picture of the soft tissues in a human body. And I found out that cervical cancer spreads absolutely different from what we had in mind from our textbooks, where cervical cancer spread, for example, was always directed transversely to the pelvic side walls. I found out, and this was another important step in my thinking, that the current ideas which surgeons have operating and before operating in palpating is not compatible, at least not accurately compatible with what the MRI is showing us. So that meant it should have been, it must be changed, because it's not the real thing. The approach, the surgical approach, which is or the surgical approach of the conventional radical hysterectomy at that time was not conform with the spread, the local spread of cervical cancer. So this was an impetus for me to examine and to look after ways which may improve this surgical technique. And there was another situation at that time. We are speaking about the 1996, 7, 8. At that time, I realized by chance that the spread of some cervical cancers seen in the MRI strikingly resembled tissue structures in the embryo forming a cervix. So I thought that this could not be chance. This could not be just by chance. This must have a deeper meaning. And that was the idea that tumor spread and morphology in terms of morphogenesis has something in common. It was a rough idea at first, a very rough idea, but it was so clear, the shape of the tissue of some cancers, cervical cancers, not all of course, but some, and the characteristic shape of a cervix developing in a human showed these similarities. And that finally, because when I realized this, I knew that the next path for me and my thinking and working could fuse. This was finally, and I was quite 40 years old or so, the fusion of the two pathways, because embryology and cancer surgery are now combined in one concept. Of course, this concept had to be developed, and just a few similarities in shapes not enough. So I started to work on this topic, and this was another road for maybe 20 years or so, until we are here right now. And this road combining embryology and embryology in terms of of topology and morphology. So that's what we need to perform surgery. We do not perform surgery with molecules. We need forms. We need topology, where are certain tissues, and we need, of course, morphology. So with morphology and topology, I started to approach the question, what has, in terms of morphology and topology, in terms, embryology, the development of the human being, in common with malignant progression of cancer. So, and I started very in the beginning in the evolution of multicellular animals, because cancer is a general disease of multicellular animals. Nearly all animals, with a few exceptions, and now I know why these are exceptions, are prone to get cancer. So at first I had to look what happened from a unicellular animal to a multicellular animal, and of course there is a big field of science considering these questions, and a lot of publications, and I had to be, of course, selective, but it became clear that a very important step in the evolution of multicellular animals is a epigenomic or epigenetically state of a cell which is stable and inheritable. So, and this cell, state of the cell, develops stepwise from the first cell with fertilized egg to the hundreds of different cell types in the adult organism by changing the epigenomic states. And so we'll have a tree of development, a branch tree of development, starting from one cell and branching until we'll have the end version. And each step of branching meant that a new cell type arose. And one thing is that with the iteration of the steps from the first cell to all the different mature cells, make cells change the character of the cell, because the first cell is totipotent. All fates of cells are integrated in this one cell. So the plasticity of this cell is immense, and with each step of development, the plasticity of the cell decreases. So the potential which a cell has becomes less and less until they are locked in their final fate at maturity. So this principle became clear to me. So we have a ladder of cell states, which are cell types. These are reproducible, so they are during a certain time stable and divide and proliferate. And the potency, the plasticity decreases. On the other side, the complexity of the structuring of such a cell is increasing. And now we had to put this information into topology. And there is, and it has to be, a strong link between the cell type and its place in the organism, its topographic identity. So a certain cell type produces a population of cells, and these cells are located in a defined anatomical position. So with each step of development, we'll have a change in the local position, and this local position becomes more and more complex. And as I told you, the plasticity of the cells, which means that one cell can change its fate, its cell type, if it's in a different location. So this plasticity decreases step by step. But because we have to consider the plasticity of cells, it is not enough to look where a cell type as a population is located in the organism, but where it can also be by changing its fate. And the integral of these populations, which a transdetermination potential makes up a morphogenetic field. And the mature derivatives of these morphogenetic fields are those spaces which will be invaded and colonized by tumor cells. And this was a long way to demonstrate and to show, because I needed a lot of cancers of different state of development on one side, and on the other side I had to go to all these different embryological developmental steps. And actually embryology and descriptive embryology is no longer has no longer been a discipline of current medical training. So I had to go back even into the late of the 19th century to get the information, the morphologic information of the stepwise development of a human being. But finally it worked. And I showed it for hundreds of cervical cancers that malignant cell invades and colonizes compartments, defined structures, anatomically defined structures in the human body, which are prepared by the development of the cell in a normal state. So, say, if to say it simply, tumor cells recapitulate, they go the way of development back. Start with a small area where they are permissive to exist, and becoming and getting into more and more larger areas, but not everywhere, not just in all directions, always bordered by limits of colonization. And these limits of colonization, the boundaries, borders, they can be, or I saw this, I realized this, are the results of the development. And I also found out that in vulvar cancer, the spread of the tumor is depending on boundaries, on tissue boundaries, which are set up by the development. So that was a very interesting observation and very exciting, of course, for me, because now I had the combination what I always looked for. The only question is why, or was at that time, the only question was why rewires tumor cells the pathway of development? Why? And then I had the idea, and I think this is the real link between embryology and malignant disease, because and this also went back to my time at Harvard Medical School, because at that time there was also a pathologist who revived the old observation of pathologists, Virchow, the German pathologist Virchow, who in the 19th century has already claimed tumors, malignant tumors, are wounds that never heal. Wounds that never heal. And indeed, all cellular and even molecular pathways and actions during wound healing, you will also find in cancer. But cancer is continuing the wounding, whereas under normal circumstances, the wound finally heals, more or less scarring, but it heals. And then I looked at what is known to wound healing in the literature. And I realized that there's one aspect in wound healing which is the missing link between cancer and embryology. And this is the fact that all wounds rewires adult cells to a previous state in development in order to repair. And this effect is global. It is canonical. And it depends of the species, how far under normal conditions, the day differentiation, the back step of a mature cell to an earlier state in the development can go. So for example, there are some animals, salamanders, for example, which can repair complete arms, legs, tails, heart, and so on. The human being can only repair a little bit. The final piece of a finger can be repaired. There is some repair capacity in the liver, for example, but it can only go a few steps back. Whereas in animals, the backward step could be almost to the beginning of organogenesis. For example, the seed cucumber can push the complete gastrointestinal tract away for the prey of any chasing animals and completely regenerate the intestinal tract. So now we have the situation that wounding is linked to day differentiation. And the cancer is producing a wound. The organism reacts by day differentiation in the intention to repair the wound. So the tumor cell is day differentiated to an earlier embryological state. And the consequence of this is that the tumor cell will get a larger area to exist. And then again, because the tumor cell is uncontrolled proliferation, the organism responds with another de-differentiation, because tumor cells are unstable. They are no longer blocked by the possibilities of a normal cell in terms of day differentiation. So with each step, tumor cells become more and more day differentiated, make more and larger and larger wound, and that drives the vicious cycle of malignant progression. And exactly that's the link between morphogenesis, embryology, by stepwise identification of the locations of cell populations, and backward day differentiation as a normal response of a pathological cell to wounding. And this is this is a malignant or a vicious cycle which really explains the malignancy in terms of progress, of invasion and destructing tissues, finally bringing the organism to death if tumor is not completely until the last cell removed. So that was a situation. For me, it was very, very interesting because the two pathways fused to one model. And once I had this developed, I went on and looked in very, very many details for many tissues and also for other cancers, despite of gynecological cancers. And I always could confirm this model, of which I have termed a model of ontogenetic cancer fields, because the cancer gets its dimensions of permissive tissues from the steps of development.
Good.
Very nice. So, Professor, we can move to question number 4.
Yeah.
So, Professor Höckel, your theories and surgical approaches, like the cancer field surgery, challenge both past and current standards of care. Early in your career, how did you navigate skepticism or resistance from other colleagues and institutional leaders? And what strategies did you find most effective in persuading others to consider and eventually adopt your innovative principles?
Yeah. I never wanted to persuade someone, you know. What I always had in mind is to convince someone, not persuade. And therefore, I used not a strategy, but a method of logical thinking. And if you apply these logical thinking, then on one hand you can falsify the conventional ideas, for example, in terms of isotropic tumor spread, and because of the logical thinking, you can also demonstrate the correctness in terms of the cancer field. For example, common thinking of local progression of a tumor is isotropic tumor spread. That means the tumor spreads in any direction which you cannot predict, you know. And therefore, the principle of local cancer surgery is to remove the tumor with an equidistant margin of healthy tissue. And the pathologist is measuring the distance to the closest resection margin and reports it. And sometimes they report all the resection margins. But if this is true, then there would be a strong relation between the distance of the resection margin and the probability of local recurrences. The larger the resection margin, the lower the probability of recurrence, and vice versa. But also this has been tested in numerous studies. There was no clear relation between these two parameters. Some studies found a relation, others did not find it. If a study was repeated, a positive result was negative. So there was never, and irrespective of the tumor type, a clear, stable, solid relation between the margin of resection and the recurrence rate, local recurrence rate could not be found. So that means that this relation does not exist, you know. By logical reasoning, it does not exist. And indeed, it did not resist because you have an anisotropic tumor spread. Tumor spreads in one direction maybe only 1 or 2 millimeters, and the other direction 3 centimeters, you know. And though if you make an average, you will never get an information. You will never get a relation between these parameters. So just simple logical reasoning disqualifies the main principle of current cancer surgery, and it proves and supports the idea of anisotropic tumor spread, which means, for example, and that's the idea of the cancer field surgery, that you can preserve tissues which may be very, very close to the tumor, but in a different compartment as compared to tumor spread within its stage-associated compartment, where you have to remove much more tissue and optimally the whole compartment to prevent recurrences. So based on the knowledge where the tumor is spreading, depending on its ontogenetic stage, that is the stage of malignant progression, you can predict the potential area of spread and design and tailor your surgery accordingly. And that was the way I tried to convince the community. And I did not just say that's what I think. I demonstrated everything in the Leipzig School of Radical Pelvic Surgery, where you two attended, and a lot of other leading gynecologic surgeons of the world attended, and I demonstrated them, and I discussed with them, and I tried to make them thinking in that logical way, and falsifying the current concepts and supporting the cancer field concept. So that's not a kind of strategy, but I always try to explain these complex situations, morphology and topology, in terms of logical reasoning. And that's what I did.
Good. So the next question is was partially answered in your previous answers. So what were a defining moment or patient case what solidified your belief in the cancer field concept?
Yeah. Once I had at least finalized the idea without all the details, because the details are really complex. If you go into all these, because the first compartment which is permissive for a tumor is quite simple, but if you go to the next and the next and the next, it becomes more and more complicated, because the tissues interacting with each other become more and more. So it's a real burst of complexity. And what I had to do is to look at hundreds of cancers. Of course, in our field, because they were available for me, hundreds of cancers in different malignant states, and always predicting the potential space, anatomical space of tumor colonization and performing surgery accordingly. And of course, with the time, because that was an action over 10, 15 years, we gathered a lot of outcome data. And we then could compare the outcome data with conventional treatment, and we found a really striking benefit of the cancer field surgery. And what makes this statement even more solid is that we never used adjuvant radiotherapy. In all the cases, and this was fortunately based on an early ethical statement where at the university I was now, I chaired the University of Leipzig, and at that time radiotherapy was not very well developed there, and when we introduced our concept and previous data and the logic of reasoning, then we got from that local university at that time the ethical approval to withhold radiation. And withholding radiation was our best and strongest argument, because we fought with our results and surgical alone against mainstream with the combination of surgery and radiotherapy, and we had much better results. So that finally supported the growth of this concept. And as you know, we had published the results in highly ranked journals, and of course I lectured in all the international societies and demonstrated also in the Leipzig school how to perform these operations and how embryology shapes the different compartments finally in the adult, which are directing particularly, for example, the radical hysterectomy, which was no longer a black box, because once we knew the building principle of the subperitoneum, which you don't see, then you know where you will have planes which are generated by the development and which you can use with your surgical instruments to accurately and precise at first expose and then remove the cancer fields for an individual tumor. So we got more and more clinical results. We more and more refined the surgery, because the surgery was not a thing which was done in a minute of inspiration. It was again a way of trial and error. We did something which was not successful and we changed it. So finally it became more and more precise to the version which we now do, which may still be optimized at one or other special site. So it was a growing of experience, growing of insights, a growing of results, clinical results, which solidified the concept. And in addition to this clinical effects, literature of the biologists supported the concept of cancer fields by molecular results. So more and more very highly ranked papers in Nature and other highly ranked journals showed on a molecular way that indeed transformed cell reprograms and rewires programs of embryological development. So this is more and more supported by insights, clinical results, experimental biological results.
Nice. So, Professor, we can move to question number 6. The adoption of the new surgical paradigms often depends on validation from the scientific community.
Mm-hmm.
Were there any particular journals or academic societies or key opinion leaders who early on recognized the potential of the cancer field surgery, and how did they support our lectures shape the dissemination of your work?
Yeah, it was very important for me to get the work published in the top journals. And fortunately, Lancet Oncology was very interested in these papers through a long period. So I could present in the Lancet Oncology several papers, starting from the earliest beginnings and early results until the final work with hundreds, almost 500 of patients. So Lancet Oncology did a lot to spread this this concept to the world. And of course, I have been in the conferences of SGO, IGCS, and so on, presenting it together with the meanwhile well-known Leipzig school. Just, I think 2 years ago, there was an important publication of the Karolinska Institute in Stockholm comparing the outcome data in the treatment of early cervical cancer by optimized conventional therapy, because in Sweden this treatment can only be done by certified surgeons in a few centers. So this is high quality, state-of-the-art conventional treatment versus our results. And as you know, there was again a strong, striking difference in outcome in favoring cancer field surgery without adjuvant radiation, whereas the conventional therapy had adjuvant radiation according to the guidelines in all situations of higher risk. So again, in addition to our own observations, there was now an objective measure with respect to conventional treatment. Meanwhile, we have also published also in the Lancet Oncology the data on vulvar cancer, and even they were even more favoring cancer field surgery compared to conventional treatment, which is still, as I told you before, relying on the concept of isotropic tumor spread. So we had help for spread by these well-recognized journals and of course by other institutions repeating our results. There's also a European trial just to repeat our results. It's a mono arm trial which demonstrated. It's not published in very high ranked papers, but it is published that in other hands surgery cancer field surgery leads to the same results. Of course, and maybe this will be a question you have in mind, what the mainstream medicine demands is a trial, a prospective randomized trial between conventional treatment and cancer field surgery. But I can only repeat what I've said many times. For me, such a study is unethical. Why? It is unethical because if you rely on logic reasoning, you have to state that the principle guiding conventional surgery in cervix cancer also is wrong, is not based on facts. And if you have a conventional treatment based on an at least inconsistent principle, and on the other side you have results which clearly demonstrate a benefit, and it represents a logic which up to now has no weakness, because the logic is clear. The embryology, everyone can look at the development of the embryo and can compare these topology and morphology with our results. It's not a miracle. It's not something which can only happen, I don't know, at a certain place during a special time. It is, you can check and prove everything. And this is not done, you know. It is very easy to say we need a prospective randomized trial, and if the results are better, okay, we will change. Then to follow reasoning, logical reasoning, falsification of principles, and the consequence out of it. So for me, I cannot agree to a randomized prospective study. Also, this is a demand of the mainstream medicine. My consequence is, okay, then this surgery may be a field for elite surgeons who are able to perform this complicated surgery and who are able to think the logical steps in that way.
Okay, the next question is number 7. Implementing cancer field surgery requires closely multidisciplinary collaboration, particularly with pathologists and radiologists, who must reinterpret traditional diagnostic paradigm. In Leipzig, how long did it take to align the specialists with your surgical principles, and what strategies did you use to motivate their adoption?
Yeah, I was fortunate in Leipzig, not only with respect to the adjuvant radiation topic in the ethical improvement, but also by both pathologists and the Department of Radiology. The strategy, if you say so, for winning the pathologist relatively early, almost in the beginning of the 21st century, was that I shared dinner with a pathologist in an Italian restaurant. No, it's not. That's not the real thing. But this pathologist in Leipzig, he was really open to that thinking, and provided us with the necessary patho and anatomical data. You know, without him and without his support in terms of looking at certain sites in the surgical specimen, which are not obligatory, not mainstream, but which are necessary to prove and check the cancer field surgery, was made by him. And he's still there, Professor Horn, and he supplied us with all these anatomical, pathoanatomical information we needed. The Department of Radiology was equipped from the beginning with very, very good MRI machines. So I had the opportunity to see of nearly all patients which we operated pre-operatively the MRI. And with the time, I learned by myself to read the MRI, particularly the T2 weighted scans. So I could compare what I see in the MRI with what I saw in the surgery. And this is still very, very important, also for everyone who is learning the techniques, who is learning the concept. He or she should be familiar with the MRI. We only need T2 weighted. That's enough. Of course, the radiologists, they have a lot of other informations which they integrate. But we also have the clinical impression, we have the palpation, we have the inspection, and the MRI. And the combination of all these information in your head and knowing the concept will guide your scalpel. And this is, in my mind, at least as important as new technology with robots and all the other things, because still it's you, and it must be you, who will be critical enough to perform. AI, artificial intelligence, they are based on billions of experience, but they are not critical. They never can be critical. But you are critical, and this ability is most important to perform the right things. Because I have just published a book, and I had unfortunately to work with artificial intelligence. I don't know if it's a he or she or it. We'll say it. It was so crazy that it made a neck for a cervical neck. So I had a picture with a pelvic section with the cervix, and the artificial intelligence, they put to every structure a name from the neck. Imagine, and this happens in artificial intelligence, because once artificial intelligence made the way, this is the neck, then everything is associated with the neck. It's like the one who has a hammer who sees always nails. So that's being on the wrong track. That's a very difficult, dangerous situation for artificial intelligence. And if you are thinking critically, you will always compare a situation in your mind with a situation which is real. And if you see a discrepancy, then you have to think, is the path the right one? Are you on the right path, or are you eventually on the wrong path? And that critical thinking is particularly important for medicine and surgery in particular. Yeah.
Good. Really good example
Okay.
of artificial intelligence.
So we can move to question number 8, Professor.
Yeah.
So while the total mesorectal excision, the TME, and complete mesocolic excision are now gold standards in colorectal cancer, gynecological oncology has been slower to adopt analogous cancer field surgical principles, despite even stronger evidence for cervical cancer and vulva cancers. In your view, what are the barriers, educational, institutional, or ideological, preventing wider acceptance? Beyond published data, what specific actions would accelerate paradigm shift in our field?
Yeah. One thing is that the development of the bowel, particularly the large bowel, is much, much simpler than the development of the genital tract. The large bowel has just one mesentery, and this mesentery is straightforward to expose surgically. Gynecologic tract has 6 mesostructures coming from 3 different developmental events. So it's much more complicated to expose and dissect the Müllerian tract, particularly the subperitoneal Müllerian tract, as compared to do it with a large bowel. So it's more complicated. It's difficult. So if you, for example, look at the stomach, total mesogastric excision, for example, is much more complicated as total mesocolic or mesorectal excision, because the stomach has 2 mesentery structures, in which are, by the rotation and the asymmetric growth, not so easy to understand directly. It is possible, and you need some knowledge of the development to identify the mesenteries for the stomach, for example. So one thing is, it's difficult. It's more difficult than large bowel surgery. And the other, I don't know if it's so, but I have the idea, more a psychological reason, that a gynecologist who masters radical hysterectomy considers himself as a master, and a master did not want to be a pupil again. So once you went through the long way and get a year-long experience in radical hysterectomy, and then you should change it, that makes an inner barrier. And so I think, I don't know, but I think that many of the gynecologists who may realize the idea of cancer field surgery are resistant, because they do not want just to start from zero when they consider themselves a master. Someone who's learning is easier to bring in to this path, but a master is very hard, and it's understandable to do this. That may be the reasons. If there are any other arguments, I don't know. For me, it was very important all the years, and still is, that if there's any inconsistency, any weakness, anything which challenges the model, I want to know it. But up to now, no one, also during all the papers and reviews of the paper, no one could present an argument which is inconsistent with the model. And for me, right now, it is always an important task to check the model with all inputs I get. But I'm not aware of any fact pointed from any other person, mainstream person, to the model demonstrating that there is a weakness or there is an inconsistency. The model is much more, as what I could just in a few words say. It's also the model is also valid for regional spread. Which lymph nodes are at risk? Not only those which are hot by radioactivity or green by fluorescence, but the concept of cancer field is also applicable for regional disease. And if you approach regional disease with that thinking, your results are better, because the sentinel technique of marking, has an inherent failure rate of false negative, because the lymph node, for example, with the metastasis is blocked to the metastasis. The metastasis blocks the lymph nodes, so the dial doesn't go into this lymph node. Or if the lymph node is not working because of fibrosis, then it is marked, but it's not able to bear a metastasis. Of course, these false negatives, if you do a lot of other aspects, particularly immunochemistry and ultra staging and so on, you may reduce it, but you never can exclude false negativity just by the method. The method and the biology always has a risk of false negativity. Whereas the cancer field model, based on development and anatomy, has not that false aspect. Of course, you can make technical faults and so on, but from the thinking, from the concept, it is another important, particularly for carcinomas, which metastasize in the lymph nodes at early stages. So the regional aspect is as important as the local aspect in terms of cancer field surgery. And that's I don't know if there are any other motivations of people's interests which are against it.
Quite logical, yes. We completely agree. The next question is number 9. Modern radiotherapy achieves excellent local control in locally advanced cervical cancers, for example, stage 2B, FIGO, and more. Given these advances, how do you define the current role of surgery in patients with locally advanced cervical cancer?
Yeah, this the answer should follow from what I've told you before, because we are diagnosing a tumor with respect to its ontogenetic stage. If we have identified the ontogenetic stage of a tumor, we know the potential tissues of spread. And if we know the potential tissue of spread, we can say, okay, we can remove this tissue with a defined morbidity. And if the morbidity increases, for example, if you have to perform cancer field surgery for OT3A cervix cancer, then the cancer field includes the bladder, not bladder muscle, but the bladder adventitia and the mesentery of the bladder. But if you remove the adventitia and mesentery, you have to remove the complete bladder. So that's the other big advantage of cancer field surgery and the cancer field concept, that you know where the limits of the operation are. And then you will apply, for example, cancer field surgery for cervix cancer only in stages OT1 and OT2, but no longer in OT3A. On the other side, we have fortunately very good results with radiotherapy in these advanced cervix cancer, because they can get high dose close to the cancer, and we don't need this surgery for advanced stage cervix cancer. On the other hand, if you have recurrence in an irradiated pelvis from cervix cancer or vaginal cancer, then LEER, which is the most extended form of cancer field surgery, will give you, if the tumor is fixed to the pelvic side wall, and most of these tumors are fixed, at least 50% chance of cure. So then again, you can apply and have an indication for cancer field surgery in a very advanced disease. But otherwise, you can, because you can compare the potential anatomy of spread with the potential of surgical treatment with acceptable morbidity, of course, or sometimes it's even not possible to do it at all. You could operate all cervix cancer up to OT3B, all, and several of OT4 too, but it has a high price to pay, and therefore, if you have an alternative in radiotherapy, which preserves the bladder, preserves the rectum, and so on, then of course radiotherapy should be preferred. But if the possibility of radiotherapy is gone, that means the patient has been irradiated, and then the tumor regrows, then cancer field surgery again will come into action.
Thank you.
Very nice. So question number 10 right now. So Professor, beyond surgical skill, what personal qualities do you think are most essential for a surgeon, scientist tackling cancer?
Yeah, this is a bit emotional, but I think honesty is very important. Honesty against yourself and against any aspect of the topic. Humility, because so much is not known. So the unknowns are still so large, and that means you always have to exercise humility when it comes to complex systems like a human being, like human organism. Just the organism is extreme complex. Then logical reasoning. There are so many philosophic concepts on logical reasoning, and it's absolutely important also for our field, I think. And endurance. Sometimes it's a long way. And courage, I think. You must have some courage. Otherwise it's very limited. Yeah. I think that's what I think is necessary, mandatory, in addition to surgical skills. Yeah.
Thank you. The next question is, if you hadn't become a surgeon, what other path might have captivated you and why?
If you have listened to what I've said, then you know that my way was a way of a lot of blind endings, and that means that a lot of coincidences finally led my way to where I now am. So it's impossible for me to really meaningful say an alternative, because if your way is structured by a lot of coincidences and you have no possibility to know what coincidences will happen, then an alternative way is not possible to really say. I could say some dreams, but that's not something what I should say. No, I think there's no alternative, and the Tina, there is no alternative. Tina, because the coincidences, they push you and they stop you and motivate you, and this is what you cannot influence.
So, Professor, the last question, number 12. So, beyond your numerous achievements, publications, and successfully treated patients, what else has driven and inspired you throughout your career? And their personal philosophies, mentors, or unexpected moments that have sustained your passion for this work?
Yeah, I think I have told you some events which paved my way during this interview. Certainly, there were a lot of people in my life who I am admiring and who probably influenced me. And this depended on the path from early childhood to my older age right now. And of course, there are really a lot of people who I am admiring. First person I admired in my mind was my teacher at the elementary school in the first class. It was a woman, a young, beautiful woman, and I was 6 years old, and I was fascinated by her. I don't know what really were the reasons why I was fascinated. I remember that I was fascinated by her. Then I had a professor in organic chemistry. He died in the Himalaya during a mountain tour, unfortunately. But he was such a brilliant person in terms of motivating someone to learn something. So what a teacher should do, an ideal teacher should do. And I always was ambivalent with chemistry, and so I told you, but because of him and his I don't know what attitude it was, but it was fantastic. He really made me interesting in chemistry to go on this way and to end this study even with the thesis. This was very impressive for me, and it's a pity that Himalaya had swallowed him. Then, when I was in the training OBGYN, there was a senior physician, and this senior physician made a large impact on me because he was so funny. He always had in the situation examining a woman, which is always something special. He had the right joke for the right place with the right person, and made gynecology for me attractive just because of this attitude of him to proceed an examination, or just to explain how to proceed and how to make a treatment. This aspect of being a joking, funny doctor impressed me. And Again, in the last time, I had very, very long and intense discussions with a theoretical physicist who is also author of our book. And the discussions with him, because he is a real logical thinker. We are just amateurs, but he is a professional. You know, he can write every logical thought into an equation, to a calculation, and this is another dimension. But still, the logical reasoning is the same, even if he is able to make the calculation and do the equations. The logical thinking is the same, and I have to explain it to him, and he has to criticize the steps of logical reasoning if they are correct or if they are weak at sometimes. So this was very important, and I have to say some of the most influencing figures in my life are from the literature. So figures of Kafka influenced me, and I'm reading now Gurna, Abdulrazak Gurna. He writes about African situations in the early 20th century and how people react on a lot of pressures and dishonesty and brutality in a really admirable art and fashion. So these figures in the literature are impressive for me. And finally, I'm also admiring my wife. She's a biologist. My daughter and my son, all of them are very, very different from me, but they have something which I admire. Yeah, that's it.
Thank you.
Thank you, Professor. Professor, I would like to ask you two more questions, if you don't mind.
Yeah.
It's going to be quick.
Yeah.
So the first one, it's about the Phoenix trial. It was a Chinese trial, a randomized controlled trial comparing the sentinel node biopsy versus the lymphadenectomy for cervical cancer.
Mm-hmm.
So the second arm, the Phoenix 2 part, compare the sentinel node biopsy with the pelvic lymphadenectomy in node positive cancer.
Mm-hmm.
And the pelvic lymphadenectomy arm had worst oncological outcomes compared with the sentinel node biopsy. How do you see the explanations for this? What's the reason?
Yeah. Actually, in order to give you a real detailed answer, I have to read the papers. Where are they published? Do you know this?
No. They were only presented on, I think, in ASCO, the Congress.
Yeah. The answer will be that lymphadenectomy, lymph node dissection, in the conventional way, is not optimal. It's not optimal. In order to remove the lymph nodes at risk, for example, you have to expose the sciatic nerve completely. You have to seal and transect a lot of parietal branches of the vein, not visceral, but parietal. Therefore, that kind of lymph node dissection, which is also the reason why they combine it with radiotherapy. I wonder if they have combined it with radiotherapy or if this is surgically alone.
It was combined with radiation.
They combined with chemo and radiation.
Yeah, you see that's another component. They use additional treatments, and therefore it could be that that the sentinel, which is not 100%, which may be 95%, if you look also on the morbidity of a total pelvic lymph node dissection, which hampers the effect of radiotherapy. You know, if you give radiotherapy in a scarred tissue, then the effect is much less than if you radiate a normal tissue. So I would agree that this is possible, that sentinel plus radiotherapy in node-positive cancers is better than lymph node dissection plus radiotherapy, because of the scarring and the less effectiveness of radiotherapy. But if you compare this with cancer field surgery, I will guess that cancer field surgery will get better results. You know, this surgery is not cancer field surgery. That's the difference. Cancer field surgery is surgery alone, always surgery alone. Maybe if you look at systematic disease, we will have, fortunately, systemic treatment to prevent distant metastasis. This is a different thing, you know. But loco-regional is surgery alone, and I dare to say that surgery alone, using cancer field concept versus sentinel plus radiotherapy, well, I cannot give you numbers because we have never done this. We can compare the absolute results because we could compare. We could make, and this may be an interesting thing to do, a direct comparison between the cases, and then look our data like the Karolinska people did. And the data of the Chinese. You said Chinese? Chinese? Yeah.
Yes,
yeah.
It was Chinese.
Yeah, but it is possible. I don't think that that could be. Yeah.
Okay, and the second question, Professor, is about, it's a more practice question. It's about the indication of the chemo alone, the chemotherapy after the cancer field surgery for node positive patients. We don't have a level 1 evidence for chemo alone for this subgroup of patients. We have a ongoing Japanese trial comparing chemo radiation against chemo alone, but is a different technique. It's not cancer field surgery. And we used to have a lot of resistance from the clinical oncologists to apply chemo alone for these patients due to the lack of evidence. So how can we manage this situation? For the radiotherapists, I think it's easier to convince them. I usually, when I start to perform the cancer field procedures, I used to invite them in the surgical field and show the surgical field after the procedure. And I used to ask them, what do you want to irradiate on this pelvis? There's no reason. So it was very easy to convince them to avoid radiation. But the clinical oncologists, which were the biggest problem, the chemo education.
Professor, sorry, please turn on your microphone. Press on the microphone button.
Who
Yes.
switched this?
Yes.
Okay. There is still a risk of distant metastasis after cancer field surgery, of course. If there is a systemic treatment reducing the distant metastasis, that would be very welcome to integrate to high-risk patients treated with cancer surgery. We had, when I was in practice in Leipzig, we had given, because it was a standard at that time, cisplatinum. Cisplatinum 75 milligrams per square meter. And we had a lot of patients who refused chemotherapy. So we could, after 10 years, make a comparison between chemotherapy treated high-risk patients and not chemotherapy treated high-risk patients. And we also made this time was a real strategy, because we offered chemotherapy only to patients with 2 and more lymph node metastases, as compared to 1 lymph node metastasis, because our idea was, if you can reduce 2 and more to the same outcome as 1, you don't need a control. Nevertheless, we had a control, because at least every second patient refused chemotherapy, and we could not identify a benefit of cisplatinum alone to prevent distant metastasis. So I don't know how any combinations with paclitaxel or any new biological systemic treatment would be effective. So this is probably really a task of future studies. But the radiotherapy argument, in addition to what you say, exactly that's how we are reasoning in Leipzig. There's another argument. And this argument is, if you irradiate all patients with high risk, then depending on your risk definition, you will overtreat a great amount of patients. So at least at the current criteria of high risk, receiving radiotherapy, I have to calculate it, but I think at least 2/3 of the patients will irradiate it without necessity, but with all the complications, with all the morbidity, So we have argued, and we presented data that if a locoregional recurrence is therapeutically treated by radiotherapy, the outcome is better than if you treat all patients with a risk for recurrence, because you are treating not 100%, but only maybe 30%, but you can treat these 30% with a much higher dose, because you know where the recurrence is, and you can apply with your new radiation techniques maybe 80 gray for the recurrences, whereas you can only give at least at maximum 50 gray everywhere in the pelvis. So a targeted therapeutic therapy for the recurrence is more effective than a treatment of all pelvises of risk with a lower dose. And actually, the Leipzig radiotherapists follow that. There is no longer a prophylactic treatment, but always a therapeutic treatment in case of locoregional recurrences after cancer field surgery. So that this argument cannot be pushed away, because it's also a logical reasoning, and of course the numbers are relevant. As far as I know, it's about 40% of the recurrences after cancer field surgery treated with chemoradiation will be salvaged. And this is quite a good number. And overall, we convinced the Leipzig radiotherapist for that strategy of treatment.
Thank you.
Very nice. Thank you.
Bruno, do you have any more questions?
No, I'm done.
So I would like just to add a little bit about Phoenix trial. We discussed with Bruno previously that possible explanation of high recurrence rate after pelvic lymph node dissection in this trial is the modification of adjuvant therapy according to lymph node dissection of sentinel and lymph node biopsy. It was related to last question of Bruno. Possibly they give chemotherapy for the lymph node dissection group, and it also proved by higher risk of para-aortic lymph node metastasis in the group of para-aortic lymph node recurrence in the group of pelvic lymph node dissection, because they give chemotherapy and do not irradiate regions with unremoved lymph nodes, and it's possible why the rate of recurrence is higher in the risk of pelvic lymph node dissection, because they do not irradiate it, irradiate the next region.
Yeah, and also we don't know what is happening after a surgical treatment with a residual tumor, and there are many several confounding factors which have to be recognized if we compare these. I have to look after the data if the study is published. When it is published, I will look it, and I'm sure that applying cancer field model, we will have an explanation.
Okay, thank you. So I suppose that's the end of this meeting. It was a very interesting and quite unique data to capture. We will share this video on our YouTube channel, because your interview is unique data in internet. There are no data about your life, your personality, and we also have more data about cancer field surgery. It's really valuable. Thank you, Professor Höckel, that you share this time with us. I hope this primer and this interview will be powerful instruments to move forward this network, to popularize cancer field surgery, to create more studies, to discuss some cases. And I suppose we will back to you with new ideas for the next webinar.
Thank you very much, Dr. Zorg.
Thank you, Professor.
Much, Dr. Resender. Always is a pleasure for me to meet you physically or digitally.
Yeah. Thank you so much. Have a nice time. Bruno, have a nice day.
Thank you. Goodbye.